lumbar degen slips, to fuse or not to fuse. So this is a screenshot. I usually ask the audience what they think this is. This is Night of the Living Dead, a 1968 classic. So the interesting thing with this movie, I'm from Pittsburgh. It was filmed outside Pittsburgh in Butler, Pennsylvania. It was filmed for a total of $112,000 and grossed just over $15 million at the box office. So still to this date, it's the #1 in terms of percentage grossing film of all time. Can't really make films for $100,000 anymore, but I put it more so for the zombie vibe. And, you know, they're coming for us. And who's they? It's payers. It's the government. It's CMS. And they look to see where they're spending money. And they're spending a lot of money on spine surgery. They spent about $13 billion on spine care last year. And so they're not worried about ingrown toenails or rashes. They're worried about interventional cardiology. They're worried about spine surgery, and spine surgery continues to spend more and more money. So this is from the 50s, is Charlton Heston from the 10 Commandments. And we all learned in training, I think any good orthopedic or neurosurgical spine resident and fellow, one of the 10 Commandments, and this is in either Proto Hebrew or Aramaic, but you know, this is one of the 10 Commandments, and thou shalt instrument and fuse spondylolisthesis, right? From the time when we started as interns, they said, look for the slip. You get the FlexX fuse, 4 millimeters, and I'd like to thank Dr. Sue for setting me up. You know, I mean, you get the microscope out, and you look for that slip. And any spondylolisthesis typically was taught a sign of instability. That in combination with stenosis, you decompress the stenosis, you stabilize the instability. And really, this is the landmark study. I always say this is the study that set forth 1 million pedicle screws. So this is Hercules and Kurz from the early 90s, now 30 years ago. It's a grand total of 50 patients, retrospective 50 patients that looked at arthrodesis versus no arthrodesis. Now this is uninstrumented arthrodesis, just posterior lateral uninstrumented arthrodesis. And not to torture you guys with literature and data, but I think it's important. What I want to draw your attention to is that they said with arthrodesis, there is potentially a little bit better improvement in back pain. In terms of lower extremity pain, there is no statistical significance between arthrodesis and no arthrodesis. And we tell all our patients and we tell our colleagues, we're not back pain surgeons, we're leg pain surgeons. We're not neck pain surgeons, we're arm pain surgeons. So, you know, this initial study really said, you know what, if you're a leg pain surgeon, fusion, no fusion, does about the same. And as you would expect, the mean vertebral motion after surgery, the non-instrumented patients moved a little bit more, but really had no statistical difference in terms of their radicular neurogenic claudication leg pain. This led to the second patient that was a Volvo Award winner with Kurz and Hercules group, with Jeff Fishgren as the lead author. And it looked at instrumentation. So what they said is, okay, fusion might do a little bit better than non-fusion. Let's add posterior lateral, let's add pedicle screws. So they said, if you instrument, those slips tend to fuse at a more predictable rate. Not surprising, right? I mean, I think we'll all agree with that. You put screws in, they fuse a little bit better. But here's what's crazy. They looked at outcomes and they said, you know what? It didn't matter if they fused or not. All patients did about the same. But what people tended to do is they looked at that original Kurz paper and said, people with arthrodesis tend to do better. And if you add screws, they arthrodese more. So if A equals B and B equals C, then A equals C. But this is the treachery of kind of using the literature to say what you want it to say instead of what it really says. And I would furthermore, I think Brian had mentioned, you know, not all slips are the same, right? So not all degenerative spondylolisthesis are created equal. You have these predominantly male patients with big, bulky, stiff facets, fixed slip, versus predominantly female. They have these bizarre sagittally oriented facets, big facet effusions, a lot of angular and translational change on flexion extension view. These two slips are absolutely different, and I do believe that. So how do you describe how these slips are different? This group looked at decompression alone for spondylolisthesis, and they said, okay, if you decompress patients, who tends to fail? Who tends to slip more? And really, it's a patient with a lot of motion, big discs, and really sagittally oriented facets. So, I mean, I'm going to try to boil all this down for you. And really, if you have all those three, and I try to tell my trainees to look for these, look how big the disc is, look how much motion on dynamic radiographs, and look at how sagittally oriented the facets are. And if you have all three of these, if you decompress alone, those are going to slip. If you have none of those, none will slip, none will have reoperation rates. So I think this is a pretty profound paper. So, you know, I bring up a lot of these. This is in the preamble for all these, in the introduction for these patients, for these papers, and I'm going to show it again and again. So randomized controlled trials support adding fusion to the decompressive procedure 4 and 5. You know what 4 and 5 is? It's the Kurz, Hercules, Fishgren series. So you will see it's like the amplification of the importance of whatever it is, 100 plus 90 patients, so 140 patients. So this is a huge Swedish registry study. So it looked at about 1,600 patients with degenerative spondylolisthesis at 4-5, 1 and 2 year follow-up. It looked at both disease-specific and general health outcome measures. It looked at decompression only versus decompression infusion. So that's really what we're talking about, right? Do you try to just decompress them alone, treat their stenotic or radicular symptoms, or do you decompress and infuse them? Patients with predominantly low back pain, sorry for all of these abbreviations, but PBP, predominantly back pain, benefited from fusion at 1 year, although may not reach minimally clinical important significance. So people who said, okay, I have a slip, I have leg pain, but my back bothers me more, maybe those patients benefit from fusion. Predominantly leg pain patients had more improvement in back pain than the decompression alone group. So if you have predominantly leg pain, your leg pain did about the same, but your back may feel better if you get fusion. But there is no statistical significance at 2 years between either decompression alone or decompression infusion. This is a pretty well done study, about 1,600 patients. You'll see that a lot of the Swedish and Scandinavian studies really are quite powerful with their numbers and their follow-up. So this is the Gogowalla study, the SLIP trial. They looked at 66 randomized patients, 70% follow-up at 4 years. Again, American study, 60% follow-up. Fusion was statistically better, physical component SF at 2 and 4 years. No difference in disability index. Fusion with more blood loss, longer hospital stay. You know, they really emphasize the reoperation rate. 34% with decompression, 14% with fusion. But it's a little bit similar to the disc arthroplasty, right? There's a lot of confirmation bias. So if you have a fusion, you often look at it and say, we fused it, I don't know what else to do. If you do a decompression alone, you often kick yourself and say, I knew it, I knew he was going to slip more, I knew the symptoms were going to recur, now they need a fusion. So I would always be hesitant to look at data that comes from the primary treating surgeon. So just keep that in your mind. So when you look at that reoperation rate, that was decided on by the primary surgeon. And New England Journal of Medicine did an interesting thing. So I want to, in the lower right-hand corner, a lot of my slide format comes from Dr. Sue. I love his format, but you can see the reference there. So New England Journal of Medicine from 2016, they put a Scandinavian study exactly after that American study. So the exact same edition of New England Journal of Medicine put the fourth study. And this is 247 patients, prospective randomized, 135 with Degen slips, 2 and 5 year follow-up, only 5 lost to follow-up. It just goes to show you a little bit of the power of socialized medicine. I could put a little dig at socialized medicine in California, but it might not be the best audience. So they looked at disease-specific and global outcomes. Mean length of hospitalization was longer in the fusion group, shorter in the decompression group. Fusion resulted in more blood loss. It was more expensive. These all I don't think anyone will argue with. There were statistically similar reoperation rates between the fusion and the decompression group. And here's what's interesting. The post-operative evaluation was not done by the surgeon. It was done by an independent physician. So the surgeon was the mere technician, and then whoever indicated the surgery and followed them afterwards decided on whether they needed reoperation. So it just gives you a little bit of insight into the difference in who may be looking at the patient post-op and deciding what they do or do not need. So among patients with stenosis, with or without slip, decompression surgery plus fusion did not result in any better clinical outcome at 2 and 5 years than decompression alone. I really do like this paper. I think it was well done. I think it was thorough. I think it was thoughtful. I think the follow-up was phenomenal. In America, it's really hard to do these big prospective studies, but I think this study was really, really nicely done. So a couple more studies. I don't want to go too long, but again, this is the introduction. It shows just how powerful the Fishgren, Hercules, and Kurz papers were. They said, hey, decompression plus instrumentation and fusion does better. So this is prospective, about 80 patients, slips greater than 4 millimeters, looked at outcome measures, and really all patients did better. And this is just decompression alone. So there's no two groups, but this just looked at people with slips and said, if we decompress them, how do they do? And there was only a 10% reoperation rate at 3 years. So pretty significant. This is another study, about 300 patients. Fusion resulted in improved back pain, but you needed to fuse 9 people to see any benefit from one. So I don't know, you have to ask as a society, is fusing 9 people worth getting one better? I know that's a tough thing to ask, but I think it's important. No difference in ODI and VAS leg. Fusion costs more. There was no difference in complications. And this was from the Norwegian group. So again, this is the introduction, often based on Hercules et al.'s paper. I just want to really emphasize the power of early, poorly powered patients and how it's really reached into our psyche. So try to move along. This is a Japanese group. This just looked at 2 different decompression techniques, and it essentially said they did well. What I found interesting is the patients that they decompressed but continued to slip, they found they still did well in terms of patient-reported outcome measures. So this whole notion, if you decompress a slip and the slip gets worse, they thereby must be doing worse clinically. This, at least by the idea, refutes it a little bit. So why do we do what we do? Well, one thing is we get paid for what we do, right? A decompression alone is a 63-047. And you can just look here, I just stepped through it. You can decompress and do an uninstrumented arthrodesis. You can add instrumentation. You can do a 360 arthrodesis, either posterior circumferential or front back. And this isn't meant to be cute or snarky, but I do think it matters to look on a more universal scale. But instrumentation's not free, right? You got to pay for the screws, the caps, the rods, the cages, to use monitoring, to use biologics. So decompression for grade 1 degenerative spondylolisthesis sounds reasonable, but how best to perform? And I just throw that out to the audience a little bit. I think there's a lot of different ways to skin a cat. I want to introduce a way that I've grown to appreciate. So you can use a midline, typical midline exposure. take down the midline structures, laminectomy, undercut the facets, get your foraminotomies out. You can do a McCullough, do a unilateral exposure. You can use a tube. Some people are doing it endoscopically. Some have talked about percutaneous, either the mild procedure or some more exotic techniques. I have a big talk on the mild procedure. I didn't want to run over, but I find that interesting too. And who's qualified to do a lumbar decompression and who's not. Again, another controversial topic. Hopefully I'll be invited back to argue that one too. So I want to introduce a technique that I've found beneficial, although a pretty significant learning curve, which is the unilateral laminectomy for bilateral decompression. Using a tube. This red block is my tube. It's delivered unilaterally. You cut the facet in a standard technique. This is much like you do a unilateral discectomy, but then you wand over and you cut across or do a lumbar laminoplasty, if you want to call it. And you open up the central canal. And if in your mind's eye, if you look at those two different decompression lines of sight, you can see how that might open up severe stenosis quite well. So this technique's been described. It's been described quite a bit by predominantly Asian groups, but it's been shown to be safe, low blood loss, similar complications. It does take a little bit longer. You can theoretically get patients out same day. Obviously, you're doing some of these bad stenosis on older, sicker patients. So I'm not a cowboy when it comes to letting people go too early. This just goes to show you that this meta-analysis favors the unilateral laminectomy, bilateral decompression versus open. This just goes to show you in diabetic patients who may be at risk of infection that tubular ULBD may be a good option. So I'm going to try to jump across. I'm going to steal this image because I like it. I'm going to leverage it into my animation. So I wanted you to imagine this technique, and hopefully this animation kind of shows it. You can see there on the right side, that was the ipsilateral decompression and the cut across the contralateral technique. You can have a little challenge getting the medial edge of the SAP on the contralateral side. But oddly enough, it's kind of more intuitive to reach under this facet coming from here than it is here. And you can see the ipsilateral facet's much more at risk, particularly, this has a little bit of facet trophism. You can see this a little bit more coronal, this a little bit more sagittal. So I might have come from the contralateral side and taken a more up and down or more sagittal approach for this one and cut under this one. But again, I stole it, so I can't fault them. So why do we instrument infuse grade 1 slips? Because we think they do and should do better as compared to decompression alone. It's intuitively attractive, right? Slip, instability. It speaks to us as orthopedists. We stabilize instability, we reduce deformity, we fuse, we knit things together that are moving pathologically. And our experience tells us that patients do well. They do well. 4 or 5 Degen Slip, love that surgery, right? However you want to do it. Open posterolateral instrumented, mid-lift with cortical screws, MIST lift. I mean, I can come up with about 8 different ways to do it right here, right? O-lift, perk screws, and try to do indirect decompression. People are doing now prone X lifts. I mean, you come up with it, someone can get a cage into the disc. And it's what we were taught. I mean, I love my mentors. Brian and I were both co-fellows. So, I learned a lot from those guys. We're American. Americans fuse more than Europeans. We get paid more for doing more. There's no bundled payments yet for all of us, or some for some of us, but I guarantee you it's coming. And when a hospital says you have $40K to spend on a stable grade 1 Degen Slip, do you want to spend 40 grand in implants and 5 grand in biologics and neuromonitoring? I don't know. I don't know the answer to that. And current evidence suggests patients may do better with more durable results, although not overwhelmingly so. I mean, it's really not astounding how well instrumenting does. So Degen Slip start at 4 millimeters. There's a reasonable debate about the validity of dynamic radiographs, but I still use them. Listhesis is not instability, right? Listhesis is a dynamic description. Instability is greater than 3 millimeters on dynamic radiographs. Benzel's study, you know, look at the facet angle, look at the disc height, look at the dynamic instability. Maybe put the idea of predominantly back pain versus leg pain in the back of your head. I mean, I like to think I tend not to be a back pain surgeon. I'm sure we're all back pain surgeons to some degree. We're predominantly leg pain surgeons, but if someone's got a lot of back pain and a slip, maybe that would tote you a little bit towards instrumentation. So where does this leave us? Sorry, I said I wasn't going to go long, but I get talking and I go long. So 4 or 5 Degen Slip between 4 and 13 millimeters with predominantly leg pain. They may be a candidate for decompression alone. Really think about it. It's crazy to say, but I've had patients do really doggone well with decompression alone. And really what I would ask of the audience, go back and look at your past 20 fusions for a Degen spondy and really how many people meet this criteria of greater than 4 millimeters static, greater than 3 millimeters dynamic, big discs, sagittally oriented facets. And just think, could I have gotten away, not gotten away, could I have given this patient a good outcome with decompression alone? Certainly a controversial topic. I give this to some implant companies. I'm often not invited back, but I'd like to thank again Brian and the COA for having me. Let me stop sharing my screen here. Hold on. You guys take it away from me.
I think I'm trying to start my video.
I was worried no one answered me. I'm like, oh my God, did I just talk for all that time? You're like, Dr. Shimer, we didn't hear any of that.
Dr. Shimer, this is funded by 5 device companies. Please close your computer immediately. Please close your computer immediately. Where did Tom go? It says I can't start my video.
He already took it from me. He's like, I've had enough. I need to finish this.
Oh, here we go.
Oh, there you are.
All right. Hopefully Bobby and Tom come back too. So I love that talk. Not just that it's controversial, but I do think the tide is shifting a little bit. I mean, certainly on this coast, I do see people doing more ULBDs and things like that for slips. It's fascinating to me. The sports study, the Weinstein study, where they looked at like outcomes for fusion with Degen spondy, they weren't even looking at slip whatever degrees or facet angles, but only 8% of that entire cohort actually had a dynamic slip. Like 93% of patients in that sports study actually only had a fixed slip. Every single patient got fused.
I would argue really unstable Degen slips is actually not that common. I mean, we all think it is, but it's really not. We know when we see it. You know, it tends to be a bigger lady. I'm sorry, but you know, and they really angularly and they slip, and you're like, that's the real deal. But a lot of these, I kind of look at it and go, I don't know. I mean, there's a little bit of a slip, but it doesn't look that bad. They're all getting fused. I mean, not all, but it's been traditionally they get fused.
So what do you think the story is? I do think that across the country, you know, somebody with a 4 millimeter slip, bulky facet, some stenosis, I think those patients are still getting fused. I know they are. They just did a survey study with like the North American Spine Society, you know, with an anonymous survey of, you know, would you fuse those patients? So what do you think the story is? People aren't into just decompressing. People are actually seeing poor outcomes from doing decompressing. It's financial. What do you think the deal is? Because the data is pretty strong.
I think oftentimes a good decompression alone is really quite hard. I mean, I really do believe that. You know, I mean, just today I had a foraminal disc and I said, oh, you know, I'm probably going to do a TLIP. It's going to be hard to get to. And I looked at it as a young guy and I said, I'm going to try to get it with a far lateral discectomy. Man, that case was brutal. I hate that case. But I think it's probably better for him. I struggled with it, did it through a tube. I think in the end, it's good. It's just like Bobby was showing some of those discs that are unstable. I look at those and it gives me angina. I think that's always why I don't jump to arthroplasty, because you always see the ones that become unstable and they were a young functional person. And you always think, man, if they just had an ACD, they wouldn't be back here and I wouldn't have to reoperate on them. So I think it's that way with slips. I think when you try to decompress a slip, you see them back. It's like a self-fulfilling prophecy. You go, I knew it. I should have fused them. I knew it. But the other 8, you did a decompression alone and you see them like once back and they're doing phenomenally. And you're like, you know what? There's nothing else to look like. Just come back if you need me. They're gone. So at least for me, I don't think I'm very money driven. I'm adverse outcome driven. I hate when people do poorly. And I'm really impacted when people do poorly. And fusions feel safe. But we all know, there can be problems with fusion too. I think that's it. I like to think the best of us. I think we're trying to do a good job and do right by patients. And a 4 or 5 Degen slip that's fused does really doggone good. I don't know what you guys think.
Bobby looks like he's itching to say something.
Yeah. I think we're jaded because, like you said, Adam, the 4 or 5 Degen spondy, when you do a 1 level, even posterolateral fusion, they do fantastic. And they don't really,
it's like an ACDF.
Yeah, it's just like the best operations ever, right? And they're the happiest people, whether they're young or they're older. And a lot of them are older people, and you're like trying to do one operation that'll keep them from having another general anesthetic. You go, oh, this is a very consistently good operation for me. So I'm going to give you something that I feel has the best chance of giving you a good outcome in my hands most of the time. So this is my but then from the other part of it, it's like, I think there's a feeling that, we have to do the right thing the first time around. Mm-hmm. And we need to give them a home run every time. And if I just decompress them, there's about a 30 to 40% chance that they're not going to do well in 4 years. And then, my practice is going to suffer for it because there are people that are going to run around and somebody's going to say, yeah, that guy should have fused you.
Yeah.
Right. And what all these studies, I think, really help us with and really validate is the fact that you can do just a decompression on this cohort of people, and they will do well. And some of them will need further surgery, but it's okay to do it. If you have good general indications and you pick the good patients, you're going to get a good outcome. And there's some people that are not always going to get better. Just kind of like disc replacements. Like, do we think that disc replacements are going to be 100% effective? ACDF's not 100% effective. Now we're giving disc replacements. Say, if I do a disc replacement, you're going to have to do well all the time. There are people that don't do well for any surgery, right? And like, I think we're putting a lot of pressure on ourselves to always try to hit the home run. And in the end, what happens is that when you tell the patients all the statistics and what to expect, and they make their own decision, I think they come up with the decision that's really right for them. Yeah. And if there's something going on, they will understand why they're in this particular predicament. It sucks for you because you feel like, oh my God, I should have just done the operation that in my gut I should have done first time.
Well, what's crazy, I think often, it's interesting, and I said it jokingly, your exact description's how I feel with CDR versus ACDF, right? Like, we have this procedure that has a pretty good track record and they do predictably well, and then we introduce something. So it's funny, I often have that discussion with my patients when deciding between CDR and arthrodesis. But I think one of the interesting things is a lot of patients who do intermediately okay, they're a little bit better with a ULBD, they don't come back. I mean, sometimes they do and they go, I got a little bit of this and I got a little bit of that, but I'm pretty happy with my procedure. And I do think as a profession, we need to think about this push to everyone being a T10 to pelvis. I mean, I know I'm going the complete opposite, but I just don't know if that's the right thing. More again, I'm sure Medtronic and NuVasive are going to be listening in.
Please stop speaking immediately.
Get that guy out of here.
Please stop.
And I don't want to take the whole night. I could talk with you guys forever, but I just don't know. I mean, I'm still like a low instrumenting guy compared to all my partners, and they do beautiful x-rays. I just don't. I look at these like little degen curves and I just kind of go, I don't know, just try a little decompression, see how they do. They're like functional people, you know, and they get a 10 to pelvis.
We'll ask you to talk about laminoplasty versus PCF next. The one last question, Adam, I have is the technical components. So, you know, I definitely believe you do a central lami, like you're taking out the inner spinous ligaments, you're taking the rongeur, and you like feel like a criminal when you're doing it. If you're doing a decompression and there's a spondy,
you're
right?
Like there's all my local bone.
You're like, right. You're like, how can it be good to rip out all the inner spinous ligaments, whatever? So, you know, for the first couple of years in practice, like, you know, we didn't really learn ULBD. So, you know, for some of these patients that had slips, I would start doing like bilateral laminotomies on each side because I feel like that preserves the midline. And then my learning curve was, you know, I would start with a McCullough retractor, then I would do, it would actually be an open procedure, but I would just kind of practice to see if I could cut across, etc. And then, you know, after 6 months to a year, you become comfortable with going really medial and cutting across. So my question to you is like, what do you think is the learning curve and the tips and tricks to a good ULBD? Do you think doing 2 laminotomies is just as good as a ULBD, or what do you think? What do you think are the keys to kind of somebody who is normally doing a lami fusion for degen spondy, but they're like, you know what, this looks interesting. How do they learn to do that?
I'm going to reference the Journal of What I Like to Do Medicine. It's one of my favorite journals. It's a classic journal. Anecdotally, leaving one side of muscle and fascia intact seems to do something. They seem to have less pain. They seem to slip less. Again, this is like completely unscientific, so I apologize a little bit for it. I started with open T-lifts because in general, my T-lift for unilateral disease is lamina spreader on the, you know, the base of the spinous, and I leave the contralateral. I would just start doing a contralateral decompression after my T-lift was done, because it's all open anyways, and see what my cut across looks like. You know, I call it a cut across. I think it's probably a better technique, a term for that. And it's pretty amazing what you can see over there. And you got to be comfortable with like pushing the dura down. And increasingly, I'm telling all my trainees, decompression is a ligamentum flavomectomy. Like we focus on all the bony stuff. If you get out all the diseased ligamentum, you've done a good decompression, almost. I mean, there's some bad stenosis. So I've been trying this thing where I get all the ligamentum out in 2 paired, like a butterfly, called like the ligamentum butterfly, you know? It's probably a complete waste of time. I probably spend way too much time. But I started with open procedures where it didn't really matter and I could always salvage by taking the midline down. It's tough though. There's a learning curve.
Yeah. Tom, let me ask you in Boston, because there's a ton of spine surgeons in Boston, somebody with a dynamic 4mm slip, collapsed disc. Well, let's say somebody with a fixed 4mm slip, collapsed disc, facets not really fluid filled, mostly buttock and leg pain. What are most people doing? Are they doing X lifts, O lift, A lift, perk screws? Are they doing ULBDs? What's the general atmosphere over there in Boston for a patient like that?
I think the Northeast in general is typically conservative and slow to change. So to be honest, I mean, Adam's talking about that impact of that Hercules landmark article, which probably if you submitted that to a journal today, you know, would have difficulty getting in. But I mean, it's got a profound impact. So yeah, no, I think long answer, but still seeing fusion posterolateral. I mean, that's pretty much the go-to. And I think, like everyone said, it's got very reliable results. So it's tough to move off it and take on a new learning curve based on this. But my experience has been, I quickly, after, seeing those articles, decompressed a lot more of these. And I would say to speak to that learning curve, but, I generally was in that kind of 40% of reoperations. So, meaning decompressions that you turn into fusions in sort of 2 to 3 years that you saw from some of those studies that were presented. And, I think it's all about patient perception, right? I think if a patient, you tell them they need a second surgery, that pretty much in their mind can either mean that first surgery failed, or, it's sort of full disclosure, like we know that this might need to happen to you, and they view that a certain way. So, I think that was really telling and sort of, validates some of the results from those studies, because that's what happens, I think, in real life as well.
Adam, last question for you. Patients with dynamic stenosis, the supine MRI, they're not that stenotic, but you stand, and they're not even that slipped. You stand them up, they slip, 4, 5, 6 millimeters, and they have leg pain. So you say, well, this is dynamic stenosis. In most people's hands, even in mine, when I see that much, I'm probably going to fuse them in a kind of front back perk technique or lateral perk technique, because I just stabilize them in their good position, right? Where they're not slipped. Do you think it would be stretched to doing ULBDs for patients even with dynamic stenosis? Because in theory, if you've released enough of the facet and the flavum, maybe they wouldn't be pinching their nerves dynamically.
Yeah, I think when you see that, you're looking at more global, and I talk about global tricompartmental. I know that's a little bit of bastardization of knee terminology, but disc and facet incompetency. I still think that hits me a little bit in the orthopedic feels. I still look at that and go, oh, I don't know, that's moving a lot. And I do like the concept of direct decompression. So some sort of, whichever flavor you want, front back or transpsoas back or lateral back, or, I went away from MIST lifts. Again, you and I, all of us can talk for days about what our given technique is, but I do like kind of a front back for that scenario. Unilateral symptoms feel different than bilateral symptoms. So if there's a rotatory component, and it's truly just that inferior articular facet driving into the lateral recess, and maybe there's a small facet cyst, there's an outbreak of facet cysts out there. I still sometimes tell people, it's unilateral leg pain, let's try a unilateral decompression, see how you do. So I do think there's a difference between the rotatory listhesis or bicompartmental disease, disc and unilateral facet, versus a more A to P. I'm probably overthinking it, but sometimes I will do a unilateral decompression for that. But on the AP, you'll see the spinuses kind of kick over at the listhesis level. And it's misinterpreted as spondylolisthesis on the lateral, but it's really kind of a rotatory. Everything's like, you can't see my hand, but everything's kind of spinning.
Adam,
I never met a facet cyst I didn't like.
Technical question. If you have a patient who's got right-sided leg pain and you want to do a unilateral decompression, do you approach it from the right side or the left side?
See, Bobby's mean. He caught me. He said it's easier to see from the contralateral side. I'm still a classicist. I still do ipsilateral. Look down onto the nerve root. It's, you want to love it contralaterally. You can usually see that edge of the SAP. You can kind of feel, or you can feel the pedicle. It's still hard to see that root. You guys are probably better than me, but I try so hard to be good. And another problem is with trainees reaching across there. You really have to let your Kerrison do the work, and your whole Kerrison shoe pushes all the dura. mean, I always worry about side bites. You know, the whole dura is coming up around your kerrison, and I kind of go, let's see how it goes. And I think all of us kind of do this. It's funny to get with a group of very, you know, thoughtful surgeons. Everyone goes, yep, yeah, it's pretty hard to bite over there. So I still think it's easier for me to let trainees under a scope where we're both looking at it do ipsilateral decompressions.
The only way to really see that, like from a ULBD when I do it, is I'm taking a lot of that upslope to the spinous process. And I'm
You take half of the spinous.
And by the time I'm done, I go, I've just done a laminectomy. So.
Well, the funny thing is, when I started doing it with T-lifts, the guy on the other side, he'd be like, yeah, I see you working. And I go over and I go, yeah, I can probably just do it from this side.
Yeah, ULBD is I think it's something where if you go to I mean, look, no device company is going to sponsor a ULBD course. So, but if you're at a course and you have a cadaver, I think it's always super valuable to practice that ULBD technique because it's pretty scary the first couple of times.
I'm telling you too. I mean, I think we have to be prepared for being able to care for patients. I mean, maybe we don't hit home runs, but maybe we hit doubles and triples with decompressions. Yeah. And I'm not saying that I'm kowtowing to payers, but we have to be thoughtful of all these heavy metal cases we're doing. I think so. You guys think?
Yeah.
I mean, it feels like it's coming. Even here in Virginia, it's kind of like people are asking more. And
well, it's probably going to come in California before it comes in anywhere else.
For Bobby and I, it's that locally, there's a lot of surgeons who, you know, would think you're crazy for fusing somebody that slipped 4 millimeters.
Wow. We're still.
They would say, what are you doing?
I think it's the opposite here. I think, and Tom can speak to it, I think in the community, if they see what I'm doing with a 5 millimeter static slip, they're like, this guy's nuts. What's he doing? Just a decompression. And I've had some patients come back and say, hey, I went to another guy and they said you did the wrong surgery.
Yeah.
And I said, okay, well, here's my data, of course, which they like gloss over and they say, yeah, but he told me it should have been fused. So I don't know. In the end, you just got to talk with your patients and do the best you can. But